At the outset, I'd like to extend my heartfelt thanks to OncoSTEM. They have been kind enough to give us this platform, which I hope in the next couple of hours we'll be discussing about what's coming up in the field of molecular biology in breast cancer. And the way it has been designed is that I will initially, because I understand we have a large group of postgraduates who are joining in this program. So I, as a sensitizer in the initially, a sort of teaser, I'm going to just brief you what is molecular biology and from the very basics to what is happening. And then we have the expert panel discussions of one which is dedicated to what is happening in the field of prognostication in molecular signatures. And most of you, those who are residents, would understand the triple negative breast cancer have been moving in terms of diagnosis as well as in terms of therapeutics as well. A new avenue is opening up in terms of triple negative breast cancer. We will have that discussion. And we will have Dr. Manjari, who founded the OncoSTEM. And welcome, Dr. Manjari. And I still distinctly remember that way back in 2016, we were together in Bangalore when we were having this ABSI. And I understand at that point of time, CanAssist was just born. And I really feel honored and privileged to tell you that it has grown hugely. And I understand this is possibly the first Indian company who has come up with the concept of molecular signatures. And today we are going to debate, of course, and debates, constructive debates and criticisms will help them to grow. And that's the reason we have this today on the web. With this brief introduction, may I now request so that we can, if we have our chief guest, Professor Bitan Chattopadhyay, and Professor Chattopadhyay, please. Professor Chattopadhyay was the head of the department of SSKM Hospital for a prolonged period, and now he is there in SSKM Hospital as professor of surgery, and he has been one of the academic pillars. And molecular biology is one of his favorite subjects, and I have had the opportunity to hear his lecture on thyroid cancer and molecular biology. And here is Dr. Professor Bitan Chattopadhyay. May I ask you to give a few words before we start into the program?
Am I audible?
Yes, Professor Chattopadhyay, you are audible.
Yes. Professor Sarkar, the executives of the OncoSTEM the pharmaceuticals, as also the distinguished speakers, and the large number of the surgeons, oncologists, the physicians, as also the postgraduates who are attending this landmark seminar on the prognostic signatures of breast cancer. I welcome you all to this landmark seminar. It gives me immense pleasure, personally, as also as a proud privilege for all of us in the West Bengal chapter of the Association of Surgeons of India to invite this galaxy of speakers from different parts of the globe, including our national leaders, to participate in this landmark seminar on this prognostic signatures of breast cancer. They are not only the great speakers, orators, but also they are great researchers on their respective field. Am I audible?
Yes, sir.
They are great researchers on their respective field. Naturally, we are eager to listen to their lectures on this great topic. In fact, particularly this breast cancer prognostic signatures, OncoDX, MammaPrint, has changed the course of treatment of breast cancer, particularly the early breast cancer, luminal A, luminal B cancers, to detect the early recurrences, as also to detect the persons who will be most responsible with the most susceptible to the chemotherapy, or rather to select those patients who will not require chemotherapy at all. Let us listen to these great orators, good speakers, good researchers on this topic. Thanking you all again for inviting the Association of Surgeons of India to be associated with this great venture. Thank you all. Hello?
Yes, sir.
Professor Sarkar?
Yeah, thank you, Dr. Chattopadhyay, for this brief introduction. Now we go to the next one, and oh, incidentally, I am supposed to give the first lecture, and if I can get Dr. Debashish Ghosh and Dr. Saifuddin Ahmed to begin with this session. Dr. Debashish Ghosh and Dr. Saifuddin Ahmed, please.
Diptendra, thank you very much for inviting us, and I have great pleasure in introducing Diptendra to open this discussion. And this is our first topic of the day today, and he wants to give us an introduction and teaser. Diptendra doesn't need an introduction to anyone, but for all people present, because there'll be a lot of people from rest of the world. I've asked a lot of my colleagues and residents from London has to join as well. And for their benefit, I must introduce Diptendra is not only a very accomplished breast surgeon, but has very keen interest and has taken genomics and genetics along the research as his research specialty. And he has been constantly involved in promoting and looking into different aspects of genomics and genetics in breast cancer. And he will be the best person to talk about the different prognostic platforms we have and our current standing today. So over to you, Diptendra.
Thank you very much. If I can ask Rahul or somebody from the Kavina to kindly allow me to share my screen.
Yes, sir. Please go ahead, sir.
I hope I am visible, isn't it?
Yes, sir. You're visible, sir.
Yeah. A warm good afternoon to everyone. And it's around 6 o'clock in the evening in Calcutta, in India. And this is possibly the first time we have been able to negotiate a time which suits five major continents. And thank you everyone for joining. Now, I have been given the task to introduce you to the topic. And I am going to tell you certain areas which are coming up, which are very relevant in prognosticating breast cancer. And the first slide is a slide that have been taken from the Murder in the Oriental Express, and that's Hercule Poirot for you. And every day, everyone possible who's sitting around you is a possible murderer. And my scientist friends tell me about a protein that they have deciphered only last evening, and they tell me that that is a potential protein, that or a gene that is going to give us a Nobel Prize. So every day a new clue is coming up, like the infodemic that you have with COVID-19, which would state that a new weapon is just at the corner of your room. What I'm going to do is decipher the biology of breast cancer and where exactly do we stand. And these are the five areas I will talk upon. Number one is causation of breast cancer. Number two, what are the role of proliferative genes and how does it impact in understanding breast cancer? What is the role of cancer stem cells and its impact? Because cancer stem cell is one thing CanAssist has brought probably for the first time in India. Number four is tumor microenvironment and the immune system, how it works. And finally, putting it into a sort of mixed bag, how things have evolved in the last 150 years. So coming to the first chapter, how it starts, and of course, all of you know, it's about the hereditary versus the sporadic cancers. And this is just an example of a gene which is known to a first year undergraduate student. And of course, you have almost 11 of them now who would vouch for the fact that it runs in the family. But you need to understand that clearly Herculopoirogenous in throughout the tumor-associated limb. Secret order is decoding the biology of cancer stem cells, which has been looked upon from the landmark publication in NEJM in 2012, which states the importance and significance of cancer stem cells that we have. Look at it. This is the classical picture from that publication. Now you have a tumor which is actually a conglomeration of differentiated cells, and possibly in the inner core there are cancer stem cells. And when you give chemotherapy, you are likely to dissolve the outer shell or the differentiated form, but the inner core is resistant, and they would go into hibernation, possibly in the bone marrow, and come back later on. So it's a sort of plasticity of the cells between a differentiated and a cancer stem cells which go on taking place, and that's possibly one of the major reasons for recurrence in the later phase. Now this is a classical picture. Now look at this carefully. You're going to find most of the cancer stem cells, as are evident by CD44 or 25 markers, are in the inner core, and they have the character to move very slowly, but once they come out towards the surface, they develop the power to move very fast, and therefore the potential to develop metastasis. And if you look at the timeline, you'll understand in the initial phase, it's only in the core, then it start to migrate to the periphery, and only in the late stage, it comes up in the periphery when dissemination ensues. Now, the next important trial that we started was to understand the heterogeneity of cancer stem cell population within the intrinsic tumor mass and the peripheral region. And this was what we found, that this is how we stain it. We have done it both by flow cytometry as well as by IHC, but IHC is the more rational thing to do in clinical practice. And based on this, we could find that there is a distribution pattern, not really very clear and obvious at this present moment, but in some cancers, it tends to be more in the center, but in others, it is equally dispersed both in the center and the periphery. So therefore, this dictates whether the cancer is going to have metastasis. The volumetric analysis, the quantitative analysis dictates whether this patient is likely to have metastasis later on or not. And this is what it happens. The mutation, we believe that it gives rise to only differentiated stem cells, differentiated cancer stem cells, but it gives rise to cancer stem cells as well. And it's a plasticity of cells that they can go into differentiated form. And on the other side, we did an in vitro test with aspirin, and we are able to get it published as the cover article in April 2016 about how aspirin can suppress the acquisition of chemoresistance in breast cancer by disrupting the NF-kappa beta IL-6, which is the most talked of molecule in COVID-19. It does have a reverse relationship in terms of cancer. Coming to the last segment, that is the tumor microenvironment and the immune status. Now, this is for postgraduates to understand, because I'm sure that is going to come as a short note, or yet it might be asked in your exam as well. Now, this is a well-known picture of coronavirus. And I'm sure you look at those spike proteins, you start feeling. And whenever I talk about corona, I prefer to use COVID. That's a less horrible name, a less stigmatized name. But this is how the virus looks like. Now, the question is, when the virus incorporates into our system, it will initially provoke an immune reaction. And at times, it can be a hyperimmune reaction giving rise to cytokine storm. But it's basically a mutation within the cell in our genetic sequences. But when it comes to cancer, now the same mutation pattern fails to generate an immune reaction. The question is, why will cancer fail to generate an immune reaction? Now, a virus in a lysogenic phase will continue to generate immune reaction. But a cancer, even it grows, it metastasizes, it does not generate an immune reaction because it's a slow exposure and the system looks at it as nothing as foreign. Why the system looks at not as foreign, and why the T effector cells, which should normally, or the naive T cells or the cytotoxic T cells would normally come and destroy, and why in cancer it is becoming completely inert and impotent, nobody knows. But it is believed it is because of the immune checkpoint modulators, the PD and the PDL1, and this was a molecule called CTL4, and this was nominated for Nobel last year. And we have TIM3, we have LAG3, and we have TIGIT. So these are the 5 chakrabuhos which is going to cover up a cancer stem, a cancer cell, and will not allow a T effector cell to destroy it. Over and above that, to top up, what happens is that the T effector cells are being regulated by the T regulatory cells. And these T regulatory cells are going to further inhibit the T effector cells. So what happens is that even if the cancer grows, there's a barrier between the T cells and the cancer. So we used to look at the histopathology slide 2.5 decades back. Look here, there is good lymphocytic infiltration. This is going to work wonders. We talked about tumor-associated lymphocytes, and we thought that that was good, but it failed because we need to know which type of lymphocytic infiltration, T cell infiltration is taking place. Mere infiltration, just try to localize it, but doesn't have any effect in terms of destroying the cancer cells. And therefore, we are undertaking this, where we try to understand the distribution of T regulatory cells. And this is our initial data, which has now grown up to almost 20 patients, where we are able to prove that both in the outer periphery, in the inner core, and in the peripheral blood, there is an increased amount of T cells, which actually inhibits the T effector cells. And therefore, the immune reaction doesn't take place. And this has become extremely important with the upcoming, which is called the immunotherapy in triple negative breast cancer. That's one area we are going to discuss today. So coming finally, the descriptions in the modern era. Now, almost 4.5 decades back, we used to tell it's a T1N0, M0 grade 1 postmenopausal lady. And that was the only information available to us. It evolved in the 1970s to a Nottingham Prognostic Index, and today we have a better form of that, EndoPredict and such other and such forth. We had started giving informations in the 80s at ER positive, PR positive, HER2 negative, T2, T1, M0, M0 grade 1 tumor with an NPI of 2.3. And now, with the available biomarkers, we are able to tell, look at, it's a luminal A cancer. And then somebody came up in the last decade, and today in India, only 5 years back, these proliferative markers have come, which is going to tell you it's a risk score 9, and you can tell, well, this patient can do well even without a systemic chemotherapy. What if we add information to them in terms of the cell line resistance, that even if you give hormone therapy, this is not going to act. So you need to add everolimus with that. What if we give an information that this patient has got a cancer stem cell load of 4%, or 7%, or 9%, and therefore it is likely to be more chemoresistant, and these are cancers which are likely to have a delayed recurrence. And finally, if I give an information about the nature of T lymphocytic infiltration and the checkpoint protein expression, whether it will be effective or not, and if you can manipulate at each level, we'll be able to give you a better solution, a better prognostication, prediction, and therapeutics to breast cancer. Thank you very much. Thank you indeed.
Thank you so much, sir. Over to the next part of the discussion. Can I call our moderator, Dr. Rosina Ahmed, to please present? Ma'am, are you there?
Yes, I'm there. Can you hear me?
Perfect, ma'am. You can share your screen.
Right. Okay. Just a minute. Good evening, everybody. Do we have all members of the panel here?
Ma'am, we have Dr. Ismail, Dr. Rishi, Dr. Mikael, and Dr. Devashish. Dr. Saifuddin is not there.
Okay, so Dr. Saifuddin couldn't join us?
Oh.
Okay, right. Well, welcome to this panel discussion, and it's great to have a panel that's stretched all over the world so that we can get opinions from different parts of the world about this new and very important topic. The issues that I would like to cover in this panel discussion. My first question is, why are surgeons discussing this? This is a meeting that is hosted by the Association of Surgeons of India, West Bengal chapter. Is it not a topic more suited to medical oncologists? Do surgeons not participate in multidisciplinary meetings where these tests are more likely to be used by their medical colleagues? So why should surgeons devote an evening to this? Is there something surgeons should take away from this meeting? We would also discuss how we discuss prognosis with a woman when she's in clinic, whether these tests are useful in predicting either late response, late recurrence, or whether they predict the benefits of chemotherapy. Appropriate test to choose. For this panel discussion, we're restricting the discussion to ER positive disease because the next panel is on triple negative disease. So first, I would like to bring in right, I seem to have some, yeah, okay. So first of all, I'd like to bring in Mr. Rishi Parameshwar from Lancaster. Rishi, are you there?
Yes, I am.
Rishi, can you hear us clearly?
Yes, I can.
Welcome. Right, let's start the discussion with you. Tell us how you discuss prognosis with a woman when you see her in clinic. What is it you do? What are the tools you use? How does it work practically?
I think to start with, I'd like to say that when you discuss prognosis, every decision we take is in the context of MDT meetings. So the prognosis and the plan will always be discussed in MDT context. And I think you've already said that we're not talking about ER negative or HER2 positive patients. We're talking about HER2 positive, sorry, ER positive, yes, and HER2 negative.
ER positive, HER2
and HER2 negative patients. And we do get prognostic information in pathology reports, so NPI will be there. And there'll be category of patients who will know that, I'll put it in two groups actually, ER positive, HER2 negative, node negative, and ER positive, HER2 negative, node positive. So those are the two group of patients I'll tell you, because these two groups are relevant in today's discussion.
Yes, of course.
Okay. So we do get some prognostic information in form of NPI. And we, of course, will take
the NPI, for those who may not be familiar with it, the NPI is
Nottingham Prognostic Index.
Yes, just because, you know, there may be some people who are not familiar with what you're talking about.
Okay, so Nottingham Prognostic Index is a validated tool, as Deeptender mentioned. It's been there in practice for decades. And it's calculated by taking into account the tumor size, which is multiplied by tumor size in centimeter, multiplied by 0.2. And then you have grade, tumor, and nodal status. And we add all of them, it gives you a number. And there'll be different risk category from very good prognosis, moderate prognostic group, poor and very poor prognostic groups. So it divides on the basis of the number you get. So that information will be there in our report, but things have moved on. We now do consider that there is more to cancer than just these clinical factors. So when we have a patient who is in moderate risk category, and I'm talking about, for example, an ER positive, HER2 negative, and node negative patient, if you have the patient who has a grade 3 disease, for example, or has a T2, and they are the patients who will have NPI in the region of moderate risk, prognosis group. So those are the patients we need to decide whether we want to give chemotherapy or not. So we use the prognostic signature Oncotype DX in those patients. And for that, we use PREDICT, which is again a validated tool. And that will give us a 10-year survival figure as to what are the survival benefit from adjuvant chemotherapy.
I'd just like to show, this is something I just downloaded just so that you can talk about it a little more easily and tell people what this PREDICT is about.
Do you want me to share that with you?
Well, I've just, rather than going to the live website, I just put in some data, say a 50-year-old woman here with ER positive, HER2 negative disease, with a 2.5 centimeter tumor of grade 3, and say 2 positive lymph nodes.
Okay,
so
if
you
you have
put in this information, and then it would give you the next page, wouldn't it?
So this is a situation where we normally would have considered giving chemotherapy.
Yes.
And now this is another dimension, because there are places where these patients might get offered, genotyping to decide whether the patient would benefit from chemotherapy or not. But we are participating in OPTIMA trial, which is another dimension here to put these patients into the trial, and they will have these prognostic signature-based decision made, whether they have chemotherapy and endocrine treatment or endocrine treatment alone. So OPTIMA trial will include patients up to 9 positive lymph nodes.
Yes, so I would just like to take, because you're using PREDICT, you used NPI and you used PREDICT. Let's just go to Dr. Jatroy in Texas and see what he would use. What would you do if you saw a patient in clinic? Do you use this PREDICT tool at all?
Well, we tend to use the Oncotype DX as the...
okay. I just wondered if you could have a quick word about the AJCC staging, because that's also moved into prognostication recently, hasn't it?
Yeah, so I mean, I think I think this is becoming less and less of a way of deciding how to manage patients, because I think the issue, I mean, this gets back into this whole issue of nodal status and these anatomical markers as being important determinants of patient management. I think increasingly we're realizing it's the biology of the disease that's paramount, and rather than the time-dependent variables, the anatomical variables, time-dependent.
This new version does include quite a bit of tumor biology. It's important to us in places where perhaps we don't always have access to the multi-gene assays.
Yeah, I mean, it's interesting. For example, nodal status, which we've taken primarily to be a time-dependent variable. I think there's a biological significance to it as well, because if you look at node-positive patients, they have a shorter interval from time to recurrence to death. It's not just simply it predicts the interval to recurrence, but also the interval from recurrence to death. So it's not simply a lead time indicator. It's also, I think, an indicator of tumor biology. So AJCC, you're correct. I mean, can be also interpreted as a biological variable, but I think the anatomical variables, I think people are beginning to realize.
Interestingly, AJCC has also included Oncotype now, hasn't it? And it downgrades a tumor, which may be a larger, it may be a T2 of sort of nearly 5 centimeter tumor, node negative, goes down into stage 1A if you have the results of the Oncotype. Okay, I think you wanted to talk about Oncotype, so let's go back to that. So there are Oncotype, and there are a lot of other prognostic signatures as well. You use the Oncotype, do you?
That's right, yes. And it's interesting, initially there was some hesitation with insurance companies paying for
Right.
oncotype. This was, several years ago when this thing started. And then they realized, of course, that they were actually saving money because a lot of patients who would have been candidates or would have administered systemic therapy were not based on the oncotype. So now it's become standard and it's something that the insurance industry and insurance companies do pay for in the United
So
States.
it's standard and you use it for more or less all your patients that fit into the criteria, do you?
Yeah, we use it for ER positive patients with up to three positive nodes.
Up to 3 positive lymph nodes. So I've put up here a wide variety of tests that are available, and maybe we can bring in Debashish Ghosh, please, from London. Debashish, are you there?
Yes,
Hello?
Rosina. Yes, Rosina.
Yes, Debashish. I just, there's so many tests available. Would you take us through what they are? What's the difference? Are they interchangeable? What do they mean?
Okay, is the slide up there? I can't see, but
Well,
anyway.
I've put up a slide which shows a lot of tests and how they classify and where the data came from, how many genes there are in the test.
Can I see that slide?
Are you not able to see this?
Ma'am, the slide is not visible.
Not visible. But anyway, I
Not
can
visible?
tell you, I know it probably. Just a quick statement, I would feel like just heard Rishi speaking from his experience in Lancaster and heard Ismail speaking to us about from States. And you can see there's a significant variation of practice. And I think within the NHS itself, there's a significant variation of practice, how we predict and say, discuss prognosis. And yes, NHS Predict was a tool which we used to use, and we have already moved to personalized medicine. And genomic tests take a very, very strong role in predicting as well as prognostications. And it's very, very important that, I am personally very familiar with 3 tests which we use regularly, which is Oncotype, Prosigna, and EndoPredict. And I was involved with the research, introduction of EndoPredict in the initial phases in UK. So, as well as we are running the trials for Prosigna as well. Now, what we see, of course, there's MammaPrint, BCI, that's the breast cancer index, Prosigna, MammaPrint, EndoPredict.
Are you able to see the slide? Because I did put all this up and
I don't
we
have
were
a slide.
sharing this earlier.
We don't
Can you
have the
see-
slide in front of me. I'm just telling you from my
Right.
memory.
Yeah, sure.
So what we
I
have,
was just wondering, it would help the audience if they can see this.
if you show it, that would be very good. But if you don't, I can just tell you. So we have MammaPrint, which was one of the first initial genomic tests which were brought in at the same time as Oncotype. And then we brought in EndoPredict, Prosigna, breast cancer index. And I think, I'm not sure about the new Indian one, but I can say one thing for sure, that each
Is
of,
that better? Can you see now?
oh, there you go. That's brilliant. Yeah.
Right.
So-
I was trying to put this up, but for some reason it went off. Anyway, go ahead.
So now it's very important why we choose each test, what is the value. It's important to understand that all these tests have very good prognostic markers. So they can tell you what are the chances of the particular patient's cancer recurring. And because we are practicing personalized medicine, statistics mean very little to us. When we sit down in front of the patient, we have a prognostic test which tells us what are the chances of that particular patient's cancer coming back in 5 years or 10 years. And that's where prognosis comes into play. And all these tests, Oncotype, MammaPrint, Prosigna, all of them are very good prognosticators. But why we have so many, what is the benefit? And there's also, do they predict what is the response of chemotherapy? What is the response of endocrine therapy? And these are the areas we have to look at when we are choosing each of these tests. Now, Oncotype DX, the largest number of tests available, we have the highest validation with Oncotype DX. It not only gives us a prognosis, chance of recurrence, but also tells us what are the chances of chemotherapy giving the patient benefit. So it is also a predictor. Mammoprint, very good prognosticator, but we don't have many trials. Right now, Minidact is looking at prediction of chemotherapy. Prosigna, very valuable in using for prognosis as well as predicting. And I'll explain, very useful in node positive cancers. So if you have a patient who has 1 to 3 nodes positive, Prosigna is very valuable. Plus, it is useful in differentiating treatment options in luminal A and luminal B tumors. So it also helps predicting endocrine therapy if you want to give it for 5 years or 10 years in patients. Same goes with EndoPredict, very useful data using clinical variables, the EP-clin ratio, and EndoPredict is valuable in node positive cancers and has a better prediction for endocrine therapy. We are still looking at the Optima trial, which will help us define if there is benefit with chemotherapy or not. Breast cancer index, I don't have personal experience with. Again, very good indicator for prognosis and also predicts the value of endocrine therapy, the longevity of endocrine therapy. I have no experience with breast IHC4 assay, so I can't say much. CanAssist, we will be hearing more. Now, one of the most important things is each of these tests are validated with a very restricted population. And the biggest failure in these various tests are they can fail in a certain population. And this is where I suppose CanAssist comes into play, because CanAssist probably is validated against an Indian population. And this is the biggest drawback in all the tests. We have found if you do the same test, Oncotype and say EndoPredict or Prosigna in the same patient, you may come out with various results. And one of the criteria we say to patients, to practicing clinicians is do not use the same test, different tests for the same patient.
Yes, and that's interesting. So which one do you use?
So we use Oncotype for node negative patients, Prosigna for Ki-67 high patients, and EndoPredict Ki-60 where we do not have. So if we do not have Ki-67 available to us, Prosigna is very valuable because we do not have NHS Ki-67 available in NHS uniformly. In the private sector, we have Ki-67 available very freely. Hence, EndoPredict becomes very easy to use. And we have a very rapid turnaround for EndoPredict available to us. I get the EndoPredict test available in 7 days. So this is where...
That's interesting. That's interesting. Now, just to take up these issues, let's move across to Singapore. And do we have Dr. Hartman there?
I'm here, yes.
Yes, so I think you also use the Oncotype, isn't that right?
Yes.
And would you like to comment on what Debashish was just telling us about how important it is to look at different populations and what needs to be validated in which population?
Yeah, maybe I can do that at the end. I was just, because you asked a little bit in the beginning whether or not, why should surgeons understand prognostication? So if you don't mind, I'll start there.
Yeah, that's absolutely fine. Please go ahead.
So a number of the panelists have already brought up the idea that we've shifted away from anatomy to biology, and we see that in our staging systems, and it's quite remarkable. If you even ignoring molecular prognostication, if you move from anatomy prognostic to a prognostic staging system, tumors that are...
I'm just actually going to show that, the AJCC, because I think it perhaps wasn't visible earlier. But if we just go to that, it might help people to understand how prognosis changes.
It's rather striking how you see how tumor biology moves them.
With the T2 tumor and N0, by taking in all these different prognostic differences, the grade and the different, the ER, PR, and HER2, a tumor could be in anything from stage 1A to stage 3A. And that is a big change in how we have to think, isn't it?
Yes, it is. So it just reminds us that anatomical staging is a composite of the age of the tumor and the biology of the tumor. And it's virtually impossible to tease the two apart by just using anatomy.
That's right.
But from a patient counseling point of view, it gets extraordinarily complicated because when the patient asks me, what stage am I in? To then in a short counseling session move from anatomy to the prognostic staging system. So I try not to do so, but I try to
Yes,
approach.
this is something we struggle with. Our patients in India, and I'm sure many of the Indian surgeons would support this, the one thing the patient wants to know is what is the stage? And it is very difficult these days to explain it to them.
Yes, it's extraordinarily difficult. So then, so the next point would be, because there are a lot of postgraduate students here, it's that recognizing that early breast cancer, the vast majority of them don't need chemotherapy. And when we give chemotherapy to the patients, more than 80% of the patients don't benefit at all from it. They either didn't need it or it didn't work. So, which is why prognostication becomes so important. So if you then start to think about, okay, should we, if we're going to allocate treatment, should it be in part surgeon-driven decision or a medical oncologist-driven decision? So I think one needs to sort that out within one's unit to decide on who orders the test and when. So what we have done in our unit is for ER positive disease is that we as surgeons, we order it. And the reason being that we live in an environment where the breasts are small. So we're very...
And the tumors are large?
The tumors are large to medium, but even a T2 tumor would often be too big for breast conserving surgery. So we've been using neoadjuvant chemotherapy quite a bit. But when TAILOR-X and responder trials came, it became obvious that it really isn't, I mean, it's not correct to give them chemotherapy without understanding the biology. So what we've then done instead is that we tried to move towards doing Oncotype DX on biopsy specimens.
Right.
So that can inform us to whether or not the patient would have sort of a poor prognosis or a good prognosis, and as the previous speaker said, would benefit. Can we tweak that underlying probability by adding chemotherapy? And I think that's where Oncotype DX becomes very meaningful because it does both. And then we would comfortably be able to use chemotherapy as a breast conserving tool. So we tried to bring as much information about prognosis and about therapy decisions before surgery, and not find out afterwards.
Yes, that's very interesting. So again, that's a change because as surgeons, we have worked a long time on trying to achieve breast conservation, and in our sort of societies in India, and I was hoping Dr. Saifuddin would be able to talk about Bangladesh too, but he's not here. But there has been resistance to breast conservation. And there is, of course, we see a few T1 disease, but we see more T2. We see a lot of larger T2. So we have exactly the problem that you were just talking about, which is that it's difficult to do a good breast conservation with that. And yet, is it appropriate to give that patient chemotherapy or not?
Right. So, I mean, the issue of breast conserving surgery would probably deserve a day by itself. But I mean, you would need a well-trained surgeon, you need radiotherapy, you need fantastic pathology because margins are so important, etc. But you asked whether or not is it important that if you have an assay that's been validated in one population, does it need to be validated in a second?
That's right.
I think in general, we call that generalizability. On average, so you could do a Turing test. You could say, you could give pathologists tumors from China, Singapore, India, Sweden, where I'm from. And you could ask them, can you tell these tumors apart? You can do any test you can possibly imagine. You can do full sort of you can sequence them. I think that they would have a very difficult time to tell them apart. And I think it's because tumor biology is not all that different across populations. Although you may see different proportions of ER positive, ER negative, HER2 positive disease, depending on where you are in the world. But if you look within each subtype, probably not huge differences. But there are other reasons to do validation, because it's also to allow doctors and patients to familiarize themselves with the test. I mean, one of the problems we've had with Oncotype DX is the financial toxicity, which is not negligible. It's actually substantial.
Yes, that is
and we've done something similar to what they've done in the UK, where even if a patient pays out of pocket, what we do is the patient pays first. If they don't need chemotherapy, then the patient pays the entire amount. But if they, however, if they need chemotherapy, waived. So it's our way to sort of get the financial toxicity out of the way.
Is that done at the level of the company that provides the test, or is it done on a local level?
So we've done it in collaboration with the company to sort of lower the threshold for the test, because we recognize that the test is meaningful and it helps inform us in our treatment decisions.
Ma'am, sorry to interrupt. 4 minutes are left for your session.
Okay. So, you know, we've covered, it's quite interesting that in the panel, everybody chooses to use Oncotype DX, and although in most situations, although Debashish told us a few things about when he uses the other test, I just wanted to go to, well, prognostic, you know, the things that we were talking about just now that are relevant to South Asia, because the cost, what you call the financial toxicity, is such an important thing for our patients. You've already explained that ethnic specific data may not be that important, but it's also interesting. I would like to just ask Rishi perhaps, what, you know, if somebody was bringing in a new test, do they have to, how would they validate it? How would they, what would you want to see as a clinician before you felt confident using that test? Is Rishi there? Maybe we can't hear.
Sorry, I was muted. Yeah, I mean, you know, we already have answered part of that question. That's
true, but you know, in the context of a new test, which was at the bottom of that chart, which is now available to us in India, and in the context of financial toxicity, I think
we want the test to be, you know, robustly validated so that we can. What is the idea? The idea is to de-escalate, you know, the systemic therapy. And the second thing we want to know is that can it have a predictable element that we can say with confidence that certain therapy is going to work. I don't think we are anywhere close to that point, but those are the things. And then the risk of distant recurrence and what kind of systemic therapy would be best suited. So these are the answers surgeons, as a simple surgeon, would like to know from a particular test. And of course, it should be, you know, financially viable for a large population.
Yes, and that's where the balance often comes. So just quickly in the last minute or two, so from data that's published, about 30% of adjuvant decisions can change after the results of a multi-gene assay. So which of the patients you would prescribe it to? Rishi, over to you.
So which patient
would you take into account? So would you do it with a woman with a small tumor, or would you want it to be a tumor of some threshold size? What about the nodal status? You did mention that the Optima trial includes patients with up to 9 involved lymph nodes.
Yes.
Would you do it for high-grade tumors or low-grade tumors? What about young patients, old patients?
Well, if you're going to use the genomic signature, then you go by the score, and you have to trust and you have to believe in it. So if
would you prescribe it for once you get the result, you go by the genomic score, of course. But what I mean is, would you prescribe it to every patient you see in front of you?
No, I don't think
Okay,
that's
so
a
how would you
pragmatic
decide?
approach. So that's
Okay,
what.
so how would you
that's what-
decide?
So that's what I said. You know, if it is a node negative patient, we use Oncotype DX as Debashish said, and the cutoff for us is that if the predict shows 10-year survival benefit of more than 3%, then chemotherapy comes into
The test
picture.
is now available for node positive patients too.
So node positive patients.
Node positive?
Yeah. So if the node positive patients are being used, so Oncotype DX is also being used for node positive patients.
Yes, that's
and
right.
Again, that is limited to low volume disease. So you can't use it in a N2 disease. It has to be N1.
Sure.
But Optima will answer whether it can be, some kind of prognostic signature can be used for N2 disease.
For people
And
with
we
much
need to
heavier
understand
nodal.
that. Sorry.
Yes, with much heavier nodal involvement.
Yes,
Absolutely.
and because if you're going to say that in a molecular the genomic signatures are eventually predictor of the disease course and impact of treatment, and if we get evidence that that's the way to go, and we are not quite there, but we have made quite significant progress in that.
What about younger or older patients? Does it matter?
Well, the subgroup analysis will say in most of the trials, whether you go MIND-ACT or whichever trial you take, you have to make exception, and you can't eliminate the clinician's judgment. For a younger population, you have to be careful. Under 50 patient, you have to look at the data more carefully rather than apply it as a blanket rule.
Okay, thank you very much. I think we're out of time. And in fact, this was where I was going to bring in a lot of the issues that Dr. Hartman talked about, but we've covered those issues too. And I think that brings us to the end of the session. Thank you all. Thank you to all the panelists for participating in this international discussion on multigene assays.
Thank you.
Thank you.
Thank you so much, ma'am. Now I'd like to hand it over to our next speaker, Dr. Manjari Bakre. Over to you, ma'am.
Well, huge thanks to Dr. Sarkar and the entire panel for being part of this. It has been absolutely wonderful discussion so far, and it was really Dr. Sarkar's idea. So huge thanks to him for coming up with the panel names and covering the entire, few continents, which is really useful insights from your valuable experience. And also huge thanks to OncoStem team and Kavina Creations for doing a great job on this. So my goal today is in 15 minutes, I will try and explain the data about Canis's breast to all of you. Let me start by sharing my screen. Okay.
In the meantime, while you are sharing your screen, if Dr. Chintamani, yes, Dr. Chintamani and Dr. Bitan Chattopadhyay, suppose are the two chairpersons. I hope both of them are there. So that after it is over, I would request you to take over the questions. Okay, thank you.
Kashish, can you please share the presentation?
I was muted earlier, so am I audible?
Kashish, can you hear me?
Yeah, I'll just share the screen. So you're audible as well.
Thank you.
Yeah, thanks, Kashish. Yes. Dr. Chintamani, did you want to say anything before I start?
No, just a huge welcome for something very, very important, something very, very Indian. So we're looking forward to listening to you. Thank you.
Yeah. So, since I realize there are many junior clinicians who have joined this presentation and people who don't know about Canis's breast, I will start by explaining what is Canis's breast and how the validation data about Canis's breast, how does it validate in Indian cohort versus Caucasian cohort, how does it look at age-based, node-based, and clinically considered low-risk patients, as well as the chemotherapy benefit Canis's breast shows. And I will end the presentation by showing comparisons of Canis's breast with the currently available tests, such as multi-gene tests, such as Oncotype and MammaPrint. and what is also commonly used, which is P67 based, luminal AB based, and IHC4 based. And I will end the presentation by showing you a brief review, if I may say, on how is Canas's breast doing in the Indian subcontinent so far. Next slide, please. So I think Dr. Rosina has covered this, and Dr. Sarkar as well, on so the use of prognostic test is now established. AJCC guidelines have included it in the guidelines to downstage the disease. However, ICMR guidelines in India still don't include these tests in the breast cancer treatment guidelines, primarily because these have not been well validated on Indian patients. And just to clarify, there are been actually quite a lot of publications about how Oncotype doesn't validate very well in Japan and in South Korea. Our majority patients are actually called as high risk instead of low risk, etc. So there are some biological differences which do crop up when we are looking at performance of this test, and hence, as a couple of the panel members said, that we need to really validate this testing on the populations on which we plan to use them. Next slide, please. So why Indian patients, why do we need a test that is developed in India? Is because Indian breast cancer patients, as you all know, are younger at onset, have a higher tumor burden, primarily come with one node positive disease, and they have primarily symptomatic, we have primarily symptomatic detection here, which is stage 2, as against the Western counterparts who are older at onset, primarily screen detected smaller tumors, and and primarily stage 1 disease. So the unmet need, when I started, if I look back at OncoStem, the whole on the founding OncoStem and developing Canas's breast, I really felt that the Western tests are useful in the West for sure, without a doubt. It's just that they are really prohibitively expensive and not well validated on our patients. So how do we come up with so I felt that the unmet need is to have a test that is developed on our patient population, and we validate it across different continents as much as possible. And so with that goal, in 2011, OncoStem was founded and Canas's breast development started. In next slide, please. So what is Canas's breast? So Canas's breast is a simple immunohistochemistry based prognostic test. So we perform immunohistochemistry on FFP blocks of patients who are eligible patients, ERPR positive, HER2 negative, stage 1, 2, up to 3 nodes. And the 5 biomarkers we look at will come into the next slide. So we look at 5 critical biomarkers which are really important in the biology of the disease, and that coupled with morphometric analysis which showcases the tumor size, tumor grade, and the node status. I mean, we absolutely understand that the clinical parameters are important in staging the disease, and we don't want to take away anything from your vast knowledge and the experience that these clinical parameters give you. So we combine both these things in a machine learning based statistical algorithm, which is a support vector machine based, and it really, because of the machine learning aspect, it helps to reiterate and understand and learn the data very robustly, and gives us a risk score, which we call Canas's breast risk score. It ranges from a value of 0 to 100, and we have a cutoff at 15.5. Below that cutoff, patients are stratified as low risk for cancer recurrence, and beyond that, they are stratified as, they're called as high risk for cancer recurrence. And the Canas's breast test is developed, this development cohort was about 298 patient samples, primarily Indian. Next slide, please. So what are these biomarkers that I'm talking about in Canas's breast? Every time I talk about biomarkers to anybody, everyone asks me, is this ERPR, HER2 and Ki67? And I say no, because these are routinely done, I think pretty much across the globe. So by adding them in our test, we are not really adding value in the test. We are only increasing probably cost of the test. So we do not look at ERPR, HER2 and Ki67. We really go beyond what we like to call proliferation index and the hormonal indices. Next slide, please. Yeah, and these are the 5 biomarkers. We look at CD44, N-cadherin, 2 cadherins, and pan-cadherin, and 2 ABC transporter proteins, ABCC4 and ABCC11. So we looked at a variety of biomarkers when we were developing CAN-assist breast, like close to 40. And we looked at systematically each by immunohistochemistry to develop these. And what we realized, what is important is this really biology before anatomy. And the event of cancer progression, when the cancer begins in the duct, really begin early. The cells have to go through EMT and then lose the cell contact, get into the bloodstream, invade the blood vessels, go out, lodge somewhere else, and then again go through MET and then become chemoresistant and lead to another tumor formation. So these are the broad steps, very presented in a very simple manner, let me put it that way. And we looked at what are the critical biomarkers involved in these steps. And we statistically, we finalized these 5 biomarkers, which are really important in the biology of recurrence. And this is the biology here. And these are the images of the 5 IHCs that we do in the lab. And these are graded quantitatively by a very talented team of oncopathologists we have, and they are well trained on these. And that's the input from this really goes into the machine learning based algorithm. Next slide, please. So as I mentioned, CAN-assist breast has undergone rigorous development and validation over the past 9 years since starting to the company in 2011. And any new test, which is the lab developed test, requires validation in analytical, that is how good is the test with respect to the methods of the test, clinical validity, how well it is validated on retrospective samples. So currently what I am going to show you data today is validation in India, US and Spain. And we do have additional studies ongoing in Europe, Australia, Italy, and Netherlands, and also in the US. And clinical utility is the prospective use of this test in a setup where patients are diagnosed on a daily basis and the test is used. And that number for us is reached about 850 patients, which I will just showcase a highlight of it. Next slide, please. In the interest of time, I'm skipping all the slides on analytical validation. Coming to clinical validation, this is the, yeah, next slide, please. Yeah. This is the CAN-assist breast data on the total cohort of 1385, which is a mixed cohort of Indian and Caucasians. And this is the CAN-assist breast is able to segregate patients into low and high risk very well in a statistically significant manner. In the Indian subcohort, the performance is again statistically significant, and also in the Caucasian patients. So CAN-assist breast is able to segregate Indian and Caucasian patients equally well with a high NPV. So it is independent of racial differences. Next slide, please. Now, all medical oncologists and surgical oncologists will be very curious about how does this is the total cohort of patients treated with and without chemotherapy. So we did a lot of subgroup analysis of this data, and this is the slide which showcases the cohort that did not receive any endocrine therapy. So the leftmost graph shows the total cohort of endocrine therapy alone treated patients. CAN-assist breast is able to segregate these patients well with a highly significant p-value. And T1N0 and T2N0 is classically considered to a large extent as clinically low risk patients. CAN-assist breast is able to find a population of a cohort of that as high risk. And CAN-assist breast, this is how it will help in finding out, in giving optimum treatment to these clinically low risk patients, because they are at high risk and they have recurred. So CAN-assist breast segregation may have helped these patients receive chemotherapy and perhaps get better outcomes. Next slide, please. Now, this is another question we used to get quite often. Is it useful in Indian population where we get the disease onset is earlier, is in younger patients? So we did a subgroup analysis where we looked at patients aged under 50 and over 50. And again, CAN-assist breast is able to segregate both the sets of patients equally well in a statistically significant manner. Next slide, please. Once again, the Indian scenario where we have one node positive patients, quite often T2N1s is really quite the predominant population in our patients. So node negative, of course, we have a lot of patients which are both chemotherapy treated and naive, and CAN-assist breast is able to segregate them. But in a node negative chemotherapy naive, that is endocrine therapy treated patients alone, CAN-assist was once again able to find the a subset of patients who were at high risk and could have been given chemotherapy. And in N1 patients also, we have a data about 450 patients, which showcases that yes, CAN-assist-based is able to segregate the node positive patients as well into statistically significant manner into two categories. Next slide, please. Now, this is the slide which is really important and important to understand, which showcases the chemotherapy benefit of this test, the CAN-assist-based offers. So graph on this Kaplan-Meier curve on the left side shows CAN-assist-based low-risk patients. So all the patients stratified as low-risk by CAN-assist-based are plotted here. The blue line shows patients treated with chemotherapy and endocrine therapy. Red line is endocrine therapy alone. So if you look at this graph, the patients, when they are stratified as low risk, whether or not they took endocrine chemotherapy, the graphs are overlapping, indicating in the low risk population, adding of chemotherapy to the regime did not help the patients in improving DMFS. Whereas on the right side, the graph shows all the patients stratified as high risk by CAN-assist-based. And if the patients did not receive chemotherapy, the red line alone, endocrine therapy alone, the patients have far worse outcome compared to the patients who receive chemotherapy in addition to endocrine therapy. Their survival improved, indicating that only the high-risk patients are getting benefited by adding chemotherapy to their regime. Next slide, please. We also did a multivariate analysis to understand if CAN-assist-based is an independent predictor of prognosis. And we looked at multiple parameters, variety of parameters, which would be important in the clinical decision making. And as you can see, amongst all the covariates, only CAN-assist-based risk score has a really significant hazard ratio, I mean high hazard ratio with a significant p-value compared to all of them which are hovering around 1 without a significant p-value, whereas CAN-assist-based is a single independent predictor of prognosis as per this analysis. Next slide, please. So then the next logical question from many clinicians to us was, how does it compare with existing tests? So we are in the process of completing many of these studies, but I'm showcasing you some of the data that we are in the process of publishing. So first one is the head-to-head comparison with Oncotype DX and MammaPrint. Next slide, please. So Oncotype DX called in this cohort of 109 patients, Oncotype DX called about 62% patients low risk, and CAN-assist called about 84% patients as low risk. And we have about 82% concordance on the low risk patients. Both tests called the same patients low risk was 82% concordance. If you look at Optima prelim data, the concordance values amongst Oncotype and other tests is much lower than this. And when you compare the negative predictive value, which showcases in the low risk, what is the likelihood of patients recurring or not. So in this case, if you look at CAN-assist-based, we have an NPV of 93, and Genomic Health Oncotype DX did the change in cutoffs. So we looked at both the cutoffs that Oncotype has used, because this is a retrospective study. When the patients were treated, they were using earlier cutoffs. So as per both, the negative predictive values are very similar. As for the TAILORx cutoff, the more recent cutoffs, the NPVs are 92, and as for the previous one, it is about 90. So there is not much difference in the negative predictive values of CAN-assist-based and Oncotype. But however, we of course remember the financial toxicity. We do it at a fraction of the cost of Oncotype DX. Next slide, please. The other important questions we wanted to also answer is the Oncotype intermediate risk zone, which of course doesn't exist now, but just to bring a closure to that question, because these patients were treated according to that, and we had about 34% patients in the intermediate risk zone. So majority of the intermediate risk zone patients were stratified as low risk by CAN-assist-based, which is what even the TAILORx trial has shown on a large scale, that majority of the intermediate risk zone patients did not really benefit from chemotherapy. Next slide, please. And these are this is how the risk stratification would look by today's TAILORx cutoff. Once again, we have, this is Oncotype DX with 0 to 25 cutoff and beyond that, and CAN-assist-based proportionality in that. So we have 83% concordance in the low risk with TAILORx cutoff 0 to 25 with Oncotype DX. Next slide, please. The Oncotype DX data was published in ASCO as an abstract in this June. MammaPrint study is still underway. This is really early data, which showcases that CAN-assist breast and mama print are doing segregation of low and high risk individually separately, as 67 and 55% both of them call as low risk and the rest as high risk. And between the two tests, we have overall concordance of 71% and 85% concordance in the low risk category of both the tests. Once again, which is very important because you are sparing these patients from giving chemotherapy. So it's really important to showcase that concordance is high or not. Next slide, please. So this is now coming to the other comparison that we can potentially, that are typically used in the clinics today, which are Ki-67, luminal A/B subtypes, and IHC4 based. Next slide, please. So Ki-67 is a matter that we can discuss till the cows come home, but because it's a variety of issues in terms of the cutoff to be used, the staining, the grading, the etc., and the antibodies used. But we try to look at this analysis from two different cutoff perspectives. So Ki-67 under 14% and under 20%, and how would the same cohort be stratified by CAN-assist breast? So if you look at the cutoff 14%, the Ki-67 was very close to each other, low and high risk, statistically not significant. Ki-67 20%, under 20%, if you increase the cutoff to 20%, the segregation is better, it is getting statistically significant. However, if you look at the same data by segregation by CAN-assist breast, we segregate them in a much better manner with the difference in DMFS very distinct and with a really significant p-value, indicating the patients who are at high risk for chemotherapy probably will benefit from, high risk for recurrence will benefit from chemotherapy. Next slide, please. We also looked at the low risk patients which are stratified by Ki-67. How would CAN-assist breast re-stratify them into, is it able to segregate them further? So what we noticed is we looked at, we did this analysis both with Ki-67 20 and 14. I'm showing you 14% data. So we found that in the Ki-67 14 cutoff use, the low risk patients were stratified by CAN-assist breast further, re-stratified, and we found a significant population of these 21% patients as high risk. So they could probably benefit from chemotherapy. And in the patients stratified as high risk by using 14% cutoff of Ki-67, we found that majority patients are actually at low risk for recurrence and may not benefit from chemotherapy. So we could probably, in this scenario, could prevent over treatment or under treatment of patients. Next slide, please. Coming to luminal A/B subtypes, of course, you all know the criteria of luminal A/B subtyping. So this is the cohort that is used for luminal, the total cohort, 972 patients used and segregated into luminal A and luminal B, assuming that the luminal A's typically are considered low risk for recurrence and can be avoided with chemotherapy, from giving chemotherapy. So the same cohort, CAN-assist breast, was able to segregate better into low and high risk in a highly significant, statistically significant manner. We also looked at how will CAN-assist breast re-stratify the luminal A population, that is this population. And we found that there were actually about 31% of patients who about 81% of those luminal AB were also stratified by CAN-assist breast as low risk. And then we also looked at how would a CAN-assist breast re-stratify the luminal B patients. And we found that about 72% of the luminal B high risk patients were actually CAN-assist breast low risk. So this was a very interesting finding that we had. So it is possible that to prevent some of those patients from giving chemotherapy as well. Next slide, please. Now coming to the final slide of comparison with IHC4 based stratification. So this is the IHC4 based risk stratification of this entire cohort, low, intermediate, and high risk. And these are the p-values between each of these risk groups. The same cohort was stratified by CAN-assist breast into low and high risk significantly at this, as you can see here. Then we looked at the intermediate risk zone of IHC4, since that can be a little bit of a dilemma how to treat those patients with intermediate risk zone. And we stratified all the intermediate IHC4 intermediate risk zone by CAN-assist breast again. And we see that majority of them actually are falling as CAN-assist breast low risk, 75%, indicating this can give a very clear answer. Performing CAN-assist breast can give a clearer answer to the patient and the clinician in terms of how to treat the patient who has fallen into IHC4 intermediate risk zone. Next slide, please.
Ma'am, there's 1 minute left.
Yeah, I'm almost done. Yes, thank you. Yeah. So now coming to my final slide, how is CAN-assist breast impacting treatment? So as Dr. Sarkar mentioned, in 2016, we started commercial sales of CAN-assist breast. It is used so far in India quite widely. More than 240 doctors have prescribed this test across 30 cities in India, and we are close to 850 patients. Majority, our typical risk proportions are 67% low risk and 33% high risk. These are the patient profiles. And from the early data, what we are seeing is there is 91% adherence of CAN-assist breast risk stratification, and about 64% of the patients have benefited by avoiding chemotherapy using CAN-assist breast. And my final slide. Summary is so I think you've seen the data. It's a robust test with cost-effective and IHC-based test. It can segregate patients independent of cohort-specific differences, age, and node. The chemotherapy benefit is observed in only high-risk patients stratified as high risk for recurrence. More than 83% concordance between CAB low-risk and Oncotype and MammaPrint low-risk categories. CAB is able to stratify patients more accurately compared to the Ki-67 and other criteria used. And early data shows that CAN-assist breast has saved more than about 64% patients from chemotherapy in a prospective manner. So just the next final slide. Yeah, so why CAN-assist breast? It is a made in India test, which has a quick turnaround time, is cost effective. It has all the regulatory approvals, which I didn't get into: CE mark, ISO, lab is enabled, and CAP accredited. We have patented the data, and we have published it in multiple publications and in conferences. And thank you all for attending, listening to me, and would be happy to take questions.
Thank you, Dr. Manjari. It was wonderful, and I've heard you. So I'm familiar with your the CAN-assist profile. There are a couple of questions in the chat box. I think you can take them later on. But one that is prominent is, how does it compare in cost to Oncotype DX or the other tests that were indicated by the previous presenters? You could just touch upon it. A lot of people are asking about the cost part of it.
Okay. So what is the cost of CAN-assist breast and Oncotype DX? Vishwa, would you like to take this?
I like that. No, you don't know, but it's cost effective. That's all he said.
It's cost effective. I just don't. Yeah.
It's fine. I'm just joking. It's cost effective. Yeah. The Oncotype DX. I mean, if you could just.
Yeah, doctor. I'll just answer. I mean, there are various price points for Oncotype and others, so we exactly don't know. But cost of CAN-assist is 60,000. That is the MRP of CAN-assist, and Oncotype, I'm not sure, it should cost around 2.8 to 3 lakhs. That's what we hear from the market.
That's right. Perfect. And about the validation part of it, you did mention one study where Sankaran was involved. Any other validation? Could you just elaborate on that? You were mentioning that you'll go around, and I mean, I really liked one comment by one of the panelists in the previous presentation, the previous panel discussion, that you just give a sample from anywhere and it'll be found just the same, because biology doesn't really change that much. So any comments on that, the validation part of it? You were to compare it with the other tests. So how did you go about it? This is another question that somebody is asking. So could you elaborate on that, please?
Sure. So we have done head-to-head comparison with Oncotype DX and with MammaPrint, because these are really the most used and remember, we are doing it in a retrospective manner. So we have follow-up of the patients, which is really important to, I mean, prospective useful, but it will take 5 more years to know. But so we actually just asked all the clinicians whom we know and whom we work with in here as well as in the US and in Spain, that if you have the test, Oncotype DX tested patient sample, then please also give us at the end the Oncotype score. And we had the same blocks shipped to us when we performed CAN-assist breast, and we sent our data to them, and they could compare and tell us what is the concordance. So essentially that is how it was done. And we found that, yeah, there is about 83% concordance in both the tests, calling the same patient low risk for cancer recurrence. And of course, the treatment was planned based on either Oncotype or Mama Print. But it was really heartening to see that we have a high concordance compared to, especially if you look at Optima prelim trial, the concordance was not this high amongst Oncotype with Prosigna, Oncotype with Mama Print, etc.
Thank you. Thank you very much. I think that should be the end of the session. Over to you, organizers.
Thank you so much, sir. Now I would like to request our next moderator, Dr. Sanjoy Chatterjee. Over to you, sir.
Thank you so very much. I must congratulate the organizers for really organizing a biology-based meeting and getting a true multidisciplinary discussion going. It's hearty to see a meeting organized by the surgeons, where we have non-surgical oncologists, and where we are discussing patient care at the highest level without any discussions on just surgery. Fantastic. So now that we have Ditendra talking to us about the biology of the disease, we have Rosina discussing about the ER/PR positive cancers, and Manjari, that was a very nice summary of your of the Canacist test that you do, and it really sort of opened up many other avenues for us to discuss. The next panel discussion here is on triple negative breast cancer, and the question that Ditendra had given us is there light at the end of the tunnel? We have a set of slides. Can I please request my colleagues from Kavina Creations to get the slides on?
Sure.
Whilst we are waiting, I mean, again, there's a significant rich cohort of surgeons who are going to discuss about TNBCs, and that sort of is a theme of this meeting, where we are not restricting ourselves to just medical oncologists or clinical oncologists to discuss on TNBCs. Now, next slide, please. Do we have Manjari? Manjari, thank you again for staying with us in this panel. We have Dr. Verma. Are you around?
Yes, I'm there.
We have Professor Chintamani, sir. Thank you very much for coming. Yes. And we have Dr. Ismail Jatoye. Professor Jatoye, are you still in?
Yes, I'm here.
We've got Dr. Saifuddin's name, but I'm unsure that he's here. Has he joined back? No.
Not yet.
And we've got two eminent surgeons from the National Health Service of UK, Dr. Ghosh and Dr. Parameshwar. Are you both in?
Yep.
Yes.
And we have Dr. Hartman from Singapore. Dr. Hartman, are you in?
I am here, yes.
Right. I had sent you all an email, and that email was a loaded mail. And I had asked you that, in triple negative breast cancers, I'm actually doing a panel with surgeons. So you as surgeons, what are your perspectives and what else do you want to discuss? And I had Dr. Parameshwar coming in, saying that, we really want to discuss the whole biology a bit in basics. But I just wondered whether any of you would like to come up with any specific areas that you want to discuss in the TNBC paradigm.
Sanjay, if I may.
Sir.
I was just looking at the participants list in the previous session, and a whole lot of postgraduates are there who got a very basic understanding of it. And I think our effort should be not to confuse them further, because they may go back home thinking that this is the beginning and the end of it, and they can get lost in these signatures. Now, when it comes to triple negative breast cancer, especially this being a cancer of this part of the world, we deal with it more often than anywhere else in the world. I'm sure it is there elsewhere too. Our incidence is also higher, up to 30%. And we don't normally, we can't put the entire triple negative into one basket and be forgetting about it, which is what generally is done. They're not all of them very bad cancers. So I like the phrase that Ditendra put. So there is light at the end of the tunnel, and I'm sure there are some good ones and there are bad ones. But that's true of breast cancer in general, I think, and true of life in the same way. It is heterogeneous, and we are not looking at all of them through one mirror, and we cannot get lost. And I don't think the first generation, these diagnostics of the genetic workup are of great use in these cancers, because most of them are usually not very good in prognosis. They are useful, but not to the extent it was in the discussion that we had on the early breast cancer, the luminal A types, where you're actually worried about whether the patient needs chemotherapy or not, it causing toxicity. Here you're basically dealing with an aggressive form of it. But as you would agree, a lot of them are not so bad tumors. I mean, you have a variety, like adenoid cystic carcinoma of the breast is triple negative, and it behaves, it's got a very indolent course, like in the parotid or elsewhere. So it does very, very well and may not need the kind of aggressive chemotherapy. But when you say triple negative breast cancer, I think one thing we must understand is that we are not talking about one problem. We are talking about multiple problems. And therefore, the good news is that there are some of them that will do very well, and there are others that would do bad in spite of whatever you do. And people are working at that. And most people are now talking about immunotherapy and the vaccines for that. So that's where we go. That's the other extreme. While we are dealing with the anatomy has taken a back seat, biology has taken the front seat, and we are taking the middle path, because we still got to be talking to patients and ourselves and between us in terms of the TNM, although it's got a little better with AJCC adding the other parameters. So what I was thinking, I'll say as a surgeon, you were asking a question. So it is essentially in an MDT decision. Many a time we are not the ones who decide on what, I mean, we shouldn't be. And we know that these patients, most of them, even if it is early breast cancer, they benefit with neoadjuvant chemotherapy, where we can, if nothing else, we can chase the PAT-CRs and know the good ones. So there's one group that has PAT-CRs and the other one that doesn't have them. But like this is the triple paradox, they do very well with it, with chemotherapy, but they don't do very well eventually. So there's so much in it that you would need to enlighten us all. Essentially for surgeons, it is like they will be discussing in an MDT, and the surgical part is to just make it amenable to conservation if possible, or to make it resectable if it is not possible to even resect.
Perfect. I think you've just set the tone, sir, over here. And so apart from downstaging and conservation, is there anything else in particular that any of the surgeons want to discuss?
Yeah, so one point I'll bring up, there's been this discussion about, and Professor Chidamani brought up a very good point, the portion of triple negatives are higher in India than they are, for example, in the United States. But one thing I'll bring up, I think the reason for that may partly, maybe even largely, be attributable to screening. So screening preferentially detects ER-positive breast cancers. The more aggressive cancers escape detection by screening and show up in the interval between screening sessions. So technology-based screening, which we do a lot of here in the United States, preferentially picks up ER-positive breast cancers, and so that may skew the results. And that may largely explain why we have high rates of ER-positive, lower rates of ER-negative.
Point well taken, Dr. Datta. Yeah, thank you.
Sorry?
I want to put a cat amongst the pigeon here. Like, one of the things we have to accept, which Dr. Chintamani just said, is that all triple negative cancers are not the same. You have the adenoid cystic cancer. Also, remember there's a metaplastic cancer, which is triple negative. Horrible cancer to deal with. I see patients from across the globe. I'm very fortunate to see that. And I see a different way the triple negative from Africa behaves. There's a different way the triple negative from India behaves. A difference in the triple negative from BRCA positive patients from the Jewish Ashkenazi population. And they are all behaving differently. And hence, I am sure, I am ignorant though, there exists certain genomic variations in these patients. It is completely contrary to somebody who just said, biology is the same. If biology was biology, I wouldn't be brown and somebody wouldn't be white. And that's the way it expresses. And also the environment is different as well, in which these tumors are expressed.
Right.
Hence, that's a very big difference we have to be aware of, and where we are. And I'm sure you know how you choose your carboplatin in certain patients, how you choose the CDK in certain patients, depending upon the genetic profile, not genomic, genetic expressions. So these are areas to look at as well.
Any other comments? Dr. Hartman and Dr. Parameshwar, would you like to comment? So we've got the choosing of the regimen as a sort of feeder that Dr. Ghosh gave us. We had Dr. Jatoy talking about, is it really true that you have a higher triple negative proportion because you don't have a screening program? So possibly you do have the same cohort. And anything else? Dr. Hartman.
Okay, I think triple negatives are interesting because I think the first thing to recognize is when something is defined by what it isn't, we pretty much don't know what it is. So it's not ER positive, it's not PR positive, it's not HER2 positive. It's sort of, I think my analogy is to say, well, I'm not Peter and I'm not Chinese and I don't live in the United States. So who am I? And if we recognize that we have a completely incomplete understanding of triple negative breast cancer, which means that it is, as many of the speakers have already said, it is not one entity. So when we start doing full exome sequencing of triple negative breast cancers, a few phenotypes start showing up. And I know that there's, at this point in time, at least 4 stable phenotypes for triple negative disease. They're basal-like, mesenchymal-like, etc. And they do behave very differently. Just like the metaplastic ones, they're extremely chemo-resistant, etc. So I think that's just my comment, is that just we need to be humble when we talk about triple negative.
The crux of the discussion, actually, it is a fantastic opening comment from all of you. So it just sets the tone. Next slide, please. We go to this, so we don't know what it is. Yes, we don't have any expression of the known IHCs, and it is a significant proportion of the cancers that we deal with. And Professor Chintamani has mentioned about a higher proportion in India of triple negatives, whilst there are conflicting reports, including reports from our center, that suggest that the proportion of triple negatives is possibly the same. And that brings us to the comment that Dr. Jatoy came in with. So, we have tumors that are more aggressive, possibly, we don't know much about. It's the proportion is possibly the same world around, apart from Africa and Latin America. And then we have cancers which are metastasizing here, there, everywhere. So how do we deal with this? And next slide, please. And we've got this scenario, and I thought I'd set the tone, a surgical panel. So, you get to see this very often, where you've got a youngish patient coming in with an inflammatory cancer, you've done a biopsy, and this comes as a triple negative invasive mammary carcinoma. You stage the patient, there's no evidence of metastatic disease, and the axillary staging does show that there is axillary lymph node that's present. So when you get these patients, of course, you're discussing your MDT. Now, would anyone within the panel say that, no, I would actually treat this patient with surgery straight away? I'm glad because, the message to all the postgraduate students over here is, for an inflammatory cancer in a middle-aged woman, we would usually downstage the disease and make this, because it's more or less a systemic disease that we think of. The next slide, please. We've got a few, the abbreviations are to your names, and I thought that, we would structure it in such a way that all of you get some comments out. So, we've discussed that, as we would not consider upfront chemotherapy, but Anjali, would your center actually give your patients combination chemotherapy? Is it a anthracycline taxane combination? Is it a sandwich regime? What is it that you use in your center?
Is the question to me? Okay, yes, I'm Arunima.
Arunima, sorry, yeah.
Okay. So as far as the regime is concerned, it depends upon the prognostic. We are now using the prognostic indicators like ER, PR, HER2. So depending on that, this is what, once the TNBC is confirmed, then usually it is a sandwich therapy that we use.
Right.
And the sandwich therapy, and as far as upfront surgery is concerned, as far as BCS is concerned, BCS in some studies has also shown that BCS is better than mastectomy without radiotherapy in these TNBC patients.
Right.
So,
okay.
So yeah.
Okay. So
yeah.
Sorry, I'll just go back to the panelists. So by sandwich therapy is something that is often used in some centers in India, and that includes Tata Memorial in Mumbai because of feasibility issues, and some centers like Tata in Jamshedpur. But would all of you agree that is that something that is used in the NHS? Say, for example, Rishi, would you like to come in? So is it a split course regime that you use?
Sanjay, can I, sorry.
Sir, please.
You see, I mean, it is not that some center would follow a policy. There is a basic oncological principle in the management of cancer. Systemic therapy, if it is doing well, complete that and then go for the local therapy. And
so I get your points. I'm just trying to...
unless, I'm sorry, I'm just completed. Unless the patient's performance status is dropping or you think patient cannot tolerate for whatever reason, we were doing it earlier that, you know, you would, after 3 cycles, you'll have the patient fit for surgery so you can might as well do it. And you get all the information from the specimen that you have sent. But these days, I think most of the centers would prefer to do it, including since you mentioned Tata, they would like anywhere they would like to complete with the systemic therapy, get the best outcome with that, and then proceed with the local therapy. That's the usual standard of care. I thought I'll make a point.
What about the NHS? I mean, you would also like to complete your systemic chemotherapy, I take it, and then you'd go ahead with your surgery?
Yes, we don't, sorry, did you ask me?
Yes, please.
Yeah, we don't use a sandwich approach. We would finish neoadjuvant chemotherapy if we decided, but I must say that TNBC doesn't always translate into neoadjuvant chemotherapy. That must be borne in mind.
What about an inflammatory cancer with the type that was given?
Well, in this case, we don't have any problem. You know, this is an inflammatory cancer.
Right.
You would give neoadjuvant chemotherapy, but we would complete. We wouldn't necessarily change.
So the question that we had for Professor Chintamani then, sir, you would definitely give neoadjuvant downstaging chemotherapy in this patient, wouldn't you?
Inflammatory cancer, Sanjay, it's a brilliant question. Thank you for that. Inflammatory breast cancer is a totally different disease, and we shouldn't confuse it with the standard. Most of them are triple negative, although there I agree. And when Lee and Tenenbaum gave this definition, they were taking into account the clinical factors too. Rapid progression in 3 to 6 months, occupying more than 3/4 of the breast, podiurance covering most of it, erythema occupying most of it, and there's no lump to be felt. These are patients where you would be giving neoadjuvant chemotherapy, actually hoping that you can do a mastectomy at the end of it. Conservation is possible in rare scenarios. So I think inflammatory cancer would change my decision completely, although it's the decision of the MDT, as I mentioned in the beginning. But by and large, inflammatory breast cancer is an aggressive form of breast cancer. I think it gets put into the same basket as LABC, the others. T4D is a different ball game altogether. So we'll need to tailor it to the patient, to the center, to the scenario. If you allow me, I'll just complete the previous answer, which was about completing the systemic therapy. Unless the patient is a non-responder or the disease is progressing and the performance status is dropping, then you might as well get a window in between and operate. By and large, I thought that part also I'll add up. So, and each TNBC does not translate into NACT, that also I agree, although there's an advantage because you can find out the path CRs and you can know that how is it going to behave eventually, so it can prognosticate better. Thank you.
Brilliant. Thank you so much. The next question is for Dr. Jatoy. We heard Rishi just mentioning that it's not all TNBCs you need to downstage. So how do you choose? Is it do all node positive TNBCs get surgery first or chemotherapy first? How is it that you choose in your MDT for chemotherapy first in a triple negative breast cancer?
So the node positivity has nothing to do,
right?
It's really the biology of the disease, but in general, okay, we give chemotherapy first for ER negative, triple negative cancers, largely based on data from the CREATE-X trial. In other words, you give neoadjuvant, you see, and if the patient has residual disease after neoadjuvant, then they're candidates for follow-on capecitabine. So that's the rationale for it. I was just going to bring up one other point, which I think we need to think about when we talk to patients. when we talk to patients about triple negative breast cancer, it's usually a gloomy prognosis that many doctors, relay to the patient. But there's a silver lining to it. And the silver lining is that after 8 years, triple negatives don't recur. Whereas after 8 years, ER positives have a residual risk of recurrence about 0.5% per year. So there's a crossover at 8 years. So the first 8 years, the triple negatives do worse than the ER positives. After that, the triple negatives actually do better than the ER positives. So patients need to realize that in the long-term perspective of things, if they survive the first 8 years, they have a much better prognosis than the ER positive patient cohort.
Thank you.
Sanjay, a very, very, very important point there. It's very similar to lung cancers, right? An aggressive cancer, if it has to come back, it comes back in 3 years, maximum 5 years. If it doesn't, then it normally doesn't come back. But with ER/PR positive, the Levin-LA types, the recurrence is uniformly, as 7 years, 8 years, you're still worried about it. So that's good news you can pass on to the patient. If it does, she has done 3 years disease-free and maybe 5 years, then you're going to be good. Thank you.
The crossover happens at about 8 years. We actually plotted the hazard curves using the SEER data, but at 8 years, after 8 years, the prognosis, after 8 years, essentially the ER negatives don't recur. The ER positives continue to have a risk of recurrence.
Thank you. We've covered all these questions. So next slide, please. The question then is, would you actually do a BRCA testing for your patients if you've got a young patient with a breast cancer which is triple negative? Would you do a BRCA testing prior to going ahead with your systemic disease? What does your MDT usually do? And we are asking the NHS UK to guide us on this. What is it that you would do in the NHS? And then we'll go to Professor Chintamani to say what his center would do in India.
So Rishi, you want to go first? Because I think there's a variation amongst NHS.
Yeah. I think in NHS, anyone who is under 50 has TNBC will have BRCA status done. But I don't think it's a routine for all patients. And, it does throw some challenges, in managing the patient when you plan to do a gene test while the patient is waiting to have surgery.
Sure. And in India, Dr. Chintamani, would you agree that we usually wouldn't like to do a BRCA in someone unless we are really got a strong family history?
You're very right. Actually, we are blessed with ICMR in the institute. They do it free of cost for us because they are doing a project. And I think we published the first one in India in 2003, the BRCA 1 and 2 mutation in Indian patients, especially North Indian patients. And they involved us in that project. So we are getting it done, but this is not something we can do. In most scenarios, it is not done.
Thank you. I think the next question we've answered that, not all inflammatory tumors need to be downstaged and conservation surgery is just an option. Otherwise, upfront surgery is still an option for triple negative breast cancer if they want to have it. Next slide, please. Now we're coming to a more sort of technical thing, but given that you sit in your MDTs and you discuss this, I'm pretty sure as surgeons you discuss about the chemotherapy regimes as well, just like non-surgeons discuss about conservation surgery, mastectomy, and reconstructions in the MDTs. So the choice of your regimes, and we are going to Singapore first. Slide back, please. A slide back, please. Yes. So the choice of your regime in Singapore, if we can have that, Dr. Hartman, for downstage.
Okay, so this is really, it becomes a decision by our medical oncologist. But when I get the patients back, it could be dose dense AC followed by taxanes. Tends to be quite common, plus minus platinums. But I just would like to say that similar to the US, we are very chemo intensive here because of the CREATE-X trial to see if there is residual disease after surgery to add on the additional regimes.
Yes, yes. What about Dr. Verma? What would you do in Jamshedpur?
I think I would agree with Dr. Hartman that it is basically the medical oncologist who makes the decision about the regimen that he has to give depending upon the various molecular and biological parameters. We don't usually make that decision, but yes, if there is a concern from the patient side, then we discuss the regimen. especially if platinum has been added and there are side effects which the patient is not tolerating, because the patient, we are the first front of the patient
Sure.
comes to us. That is the only time we get into that. Otherwise, the medical oncologist usually
Right.
takes.
And Dr. Ghosh or Dr. Parameshwar, what about you and your MDTs? Is it an anthracycline taxane combination usually?
AC or AC plus Taxol, and if they're BRCA positive, carboplatin is added to it.
And it would start off as a dose dense initially. I mean, I think.
But depends upon the patient's fitness as well. How they we sometimes start with Taxol initially and then follow it up with dose dense later on.
Right.
And then or the reverse, but usually both, and then carboplatin if it's BRCA positive.
Right. So we're sort of into this that, if it is only BRCA positive, you'd give carboplatin, otherwise you'd hold the platinum in your center. What, anyone who would actually propose platinum use, like paclitaxel, carboplatin, followed by anthracyclines in their regime, and I mean, I know it's technical medical oncology issues, but I'm sure your MDTs discussed this, so I just thought I'd bring this up.
In a younger patient, yes, in a younger patient, especially in patients coming from Africa, we use that and they have the best responses. And this is where I want to say patients from south of India and Africa, triple negative, they respond beautifully to carboplatin and Taxol.
Dr. Ghosh, you're actually making a comment which is very stimulating in that, so you're giving a geographical sort of twist into the so it's like a genomic geographical variation that you're talking about.
Yes.
Would there be any data that you have to support
it is coming out. Wait, it's coming out soon.
Right. Okay. Next slide, please. We've talked about the BRCA. I think there's very little discussion. If someone's BRCA positive, yes, adding platinum is an option, a strong option that you'd give to your patients with the risk of toxicities. Now, these are the studies that looked at the addition of carboplatin, and they showed that there's an increased response rate, but none of the studies showed that there's an overall survival benefit. In fact, apart from the JEPAR-6 study, there was no benefit even in the disease-free survival in most of them. Now that makes it very, very tricky. Is it that we're using platinum in more patients than that is required and giving them more toxicities, or is it we are using less platinum than that is required? We as medical oncologists lack the knowledge of who to use platinum or not, apart from the ones that we already know, the BRCA ones. We look forward to Dr. Ghosh's paper on the geographical and the genomic markers that we can try and use carboplatin in for. Next slide, please.
Sanjay, may I ask something there?
Sure.
Because I asked my medical oncologist, and there was a question that you had put for us. They keep it for the high risk premenopausal young women and the dose dense chemotherapy. But I often ask them a question with carboplatin, with the therapy that you just mentioned. If in neoadjuvant setting the patient has responded, not responded not adequately, or say let's see that the patient has got PCR, we treated, and if she develops a second primary, which is known in triple negative to happen, can we use the platins again? Or that's one thing which I asked him. Is it safe to use it again, the same therapy? And his answer was, I must share with you, that if there's been a reasonable gap of, say, 3 to 4 years after the therapy has been given and patient has got a new primary, then maybe you can use it. You can still use it because it's toxic. That's why I was asking your comments on that.
So I think, where we are debating on the first use of a platinum, the use of a platinum second time is possibly without a genetic, marker, without a BRCA positive.
A genetic marker, if given once and patient has a new primary, can we use it again? That was my question.
Without a genetic marker, I wouldn't. But if someone's got BRCA positivity, I could actually re-challenge if there is appropriate marrow reserve in the patient, yes. And someone's got a good response initially. So I think, can we just go to the next slide, please? Next slide, please. Right, we can't go to the next slide, is it? This is the list of toxicities. And, this is from the Italian team that actually did a good meta-analysis, which showed that there's significant toxicities with the use of platinum. Next slide, please. We talked about immunotherapy, and there is this use of immunotherapy even in the neoadjuvant setting, where paclitaxel carboplatin along with pembrolizumab, we are looking at the keynote group of studies, the keynote 522, showed that there is an improved response rate, and it was a phase 3 randomized study. Now I really want to know what you would use surgeons as a first line, that like you mentioned, Dr. Verma and the others, as a first line where the patients come in, they meet us, they go back to you, this doctor is telling me about anthracycline, taxanes, Tosdens, then adding carboplatin, and now they're saying immunotherapy. Is this data strong enough for you to change practice?
So sorry to interrupt. So the time is up, just letting you know. So.
Right. So we'll take this question as the last question then, and then we'll move on.
Now, first of all, how do you choose your patient for immunotherapy?
Right.
I think that's the key. And if you read about it, it is supposed to be targeted only to the cancer cell. The rest of the toxicity should be less, although it's very toxic when you combine the whole thing. I mean, there's no point killing the patient and treating the disease. So that's where you need to take a call. And I think it's a tough decision, personally speaking. As a surgeon, if you ask me, as it is, it looks very complicated. The answer would be, let's not make simple things more complicated. So we need to know more about it. And the same applies to the vaccine. There's one, I think FDA approved one. There's one drug that is still pending to come through, and they're using it very, very selectively. You should be guiding us. You should be telling us. What do you think? Is there any light at the end of the tunnel?
Right. So for immunotherapy, the keynote study actually didn't have a target. They actually gave the pembrolizumab across patients, and that's the problem. And that's in the neoadjuvant setting. However, in the metastatic setting, in the PD-L1 positive tumors, the use of atezolizumab, like you rightly say, did improve the disease-free survival and overall survival, along with the use of nab-paclitaxel. Now, yes, that is a breakthrough. However, that was the Impassion 130. Or the next generation of the study, which was Impassion 131, showed paclitaxel along with atezolizumab did not, and this is not yet been published, did not actually improve the disease-free survival. So I think we really do not know the basis, the markers of using immunotherapy. And we're running out of time. I had I think Dr. Hartman mentioned about the 4 classifications that we've come up with in terms of the triple negative cancers, which we can't discuss now because of lack of time, but these are emerging options. Yes, the androgen receptor positive luminal type tumors, something that we can give, bicalutamide or enzalutamide. Yes, there is phase 2 data on it in the metastatic setting. The use there is loads of data coming through on the use of atezolizumab, pembrolizumab in the curative setting as well. So there are markers that are being looked at. In terms of the luminal, the non-luminal tumors, the use of in the mesenchymal tumors, the ones that we talked about, the metaplastic cancers, which are really horrible, there's very little that we know what can be done. In fact, we treat them as sarcomas, whilst this sort of basal-like 1 and 2, these are the ones that are more responsive. In fact, the BRCA1 are the basal-like 1 tumors. They're more responsive to the chemotherapies that we prescribe, and the response rates can be as high as 50–55%. Now, simple anthracycline and taxane as the bottom line, given without the split course as a dose-dense regime, like you rightly point out, Dr. Chintamani, is something that gives a response rate of around 40–50–60%. Okay. And the addition of further, pembrolizumab immunotherapy is something that can come up with more markers and more data through. There are also PI3 kinase inhibitors, lots of study going in with that. So yes, well, I would like to say yes, there is likely to be light at the end of the tunnel, rather than saying that, we all know everything. I think, maybe possibly 3 years down the line, we'll have more data.
Can I give you two more areas? Look at proton beam therapy, look at theranostics using lutetium tagged targets. These are 2 other studies coming through.
We have looked at proton beam. In fact, yeah, you're right. The proton data on TNBC as a neoadjuvant therapy is something that has been looked at, and it's pretty interesting.
And the theranostics, which the
theranostics data is much more complex, so it's just about in its initial stages. Yes.
Yeah. So we're going to be publishing that as well. Means you've just showed up Peter Smith. He's my oncologist, actually.
Oh wow.
All right.
Thank you so much. I think we just leave it here. And again, it was just a pleasure getting to know how you as surgeons would deal with something as complex as triple negative breast cancer. Thank you, everyone.
Okay.
Just before we close, can I just say one thing, that OncoStem is actually also
Oh,
working.
sorry, Dr. Bakri. I'm so sorry. Please, yes. Please tell us what more you have. Yes.
So OncoStem is also working on developing a test for triple negative breast cancers. From what I hear from the panel this evening is that there are triple negatives who actually do well, and it's not not every triple negative patient has a very high risk disease and she recurs within like multiple times, etc. So we essentially are developing a test which will help us prognosticate the triple negative patients who would have a higher risk of recurrence versus not. We don't mean to change any chemotherapy regimens, treatments at this point. The bigger goal of the company is to really find great biomarkers which are underlying the triple negative biology, because they really, if you look at it, we don't have a single Herceptin equivalent in triple negatives today, or pertuzumab or TDM1. So the goal is to do this, to develop a test which will prognosticate the patients, and in return will give us good biomarkers against which we can develop targeted drugs. And so we are in that journey, and we really look forward to working with many of you to develop. The test is under development, so we look forward to validating partners to validate the test.
We look forward to working with OncoStem on India-specific data.
Thank you so much. And it was an excellent panel discussion. Enjoyed it. Thank you all.
Thank you.
Right, back to the organizers, please.
Thank you very much, Sanjay. It was a fantastic panel discussion, very enlightening. And I hope in future we are going to see more lights at the end of the tunnel. That's for sure. And I hope most of the postgraduates who have been participating in this short CME for 2 hours have got a basic idea of how things are coming up in the field of molecular biology in terms of prognostication. And as Dr. Bakre just told, that the TNBC is another area. It's a heterogeneous disease, and you have a large number of subfractions of TNBC, and TNBC is just on the passing nomenclature. It would rather be better to tell it's a basal type and then subclassify it. Thank you all the speakers, but before I end and hand it over to Dr. Madhumita, I'd request all the speakers who have participated, if you could kindly go to the chat, and if you find that if there is any specific question that needs to be answered, it would be great if you just pass on information to the general as well as to the specific person who is asking the questions. Thank you once again. Thank you, Dr. Debashish, Dr. Rishi, Dr. Hartman, Dr. Ismail Jatui, and finally, I suppose Dr. Saifuddin couldn't come, but I have a large number of representations from Bangladesh, Dr. AFM Anwar Hussain and Dr. Mizanu, and I have Dr. Krishna Rupa Majumdar who joined from Bangladesh. Thank you very much for joining here, and I hand it over to Dr. Madhumita for a few words, please.
Ma'am, you'll have to unmute your mic.
Hello, am I audible?
Yeah, Madhumita, you are audible.
So this was a very well organized and informative webinar, and I congratulate the organizers for that. And I'm certain that everyone in the audience, the postgraduates, the general surgeons, oncosurgeons, oncologists, all have benefited from the talk. So on behalf of the Association of Surgeons of India, West Bengal State Chapter, I thank all the faculties for sparing their valuable time in this pandemic. And I also thank the OncoStem team and Kavina Creations for organizing this webinar on such an important and interesting topic, involving speakers all over the globe. Thank you all.
On behalf of Kavina Creations and OncoStem, once again, I thank you all for participating. I know it's a bit too late in Singapore, and it's probably past your lunchtime in the UK and past your breakfast time, well past your breakfast time in the US. So please go ahead with your day. Have a great day. And thank you all once again for participating in this fantastic webinar.
Thank you.
Thank you.
Thank you, everyone. With ma'am's permission, can I end the meeting?
Sure. Yes.
Sure. Thank you so much, ma'am. Thank you, ma'am. Thank you, everyone.
Thank you.